Hello, everyone. This week I will talk about medical errors. And medical errors are a serious public health problem and a leading cause of death in the United States and everywhere else. Medical errors have a high cost and they negatively impact the patient care, the family of the patient, the involved clinician, and the healthcare organization. So it's important for everyone involved. They have a tremendous psychological effect, specifically on the professionals involved in the specific medical error. That's due to the feeling of guilt, feeling of anger, inadequacy, depression, and even sometimes suicidal ideation. That's due to the stress associated with the case itself and with the impending legal actions that might follow any medical error. So, really, it's an important topic to highlight and discuss, and that's why I picked this topic for this week video. So, 25 years ago, on December 1999, the Institute of Medicine, IOM, released a famous report known as To Err is Human, Building a Safer Health System. The committee found that the majority of medical errors do not result from individual recklessness, but usually because of systematic flaws or weakness in the way the health system is organized. And this report emphasized the importance of reporting medical errors to learn from them and to work towards preventing them in the future and building patient safety culture in our healthcare organizations. And up to date, it's the main reference for patient safety practices worldwide. Everyone involved in quality and safety knows about the report To Err is Human. So now let's define the various types of medical errors and provide examples for each of them. Let's start with error itself. The Agency of Healthcare Research and Quality, AHRQ, which is a federal agency that works to improve the quality and safety in healthcare in the United States, defines error as an act of commission, that means doing something wrong, or omission, which is failing to do the right thing. Either that commission or omission lead to an undesirable outcome or significant potential for such an outcome to happen. That's the definition of error, either commission wrong thing or omission of a right thing. And the end result or the outcome is undesirable. So, as I said earlier, it's usually a system defect, not a personal defect. That's the main idea. And it requires system analysis to point to the flaws or the weaknesses in the process or the system that led to that error to happen. So there is a famous model used in healthcare right now, and it's called the Swiss cheese model. As you can see here in this slide, the model of multiple cheese in a row. This model was firstly explained by a British psychologist named James Reason, who used this model to analyze industrial accidents and describe them. The notion of the Swiss cheese model is that most accidents result from multiple smaller errors in the environment, right? And they lead, when they stacked over each other, they lead to serious system flaws and lead to accidents to happen or events or errors to happen. So this model has an explanatory power and points towards the solutions inevitably, right? By trying to identify the holes in the system or the process to avoid lining them up and prevent adverse events from happening. So it's a simple idea, yet very crucial to understand how errors or accidents happen by having multiple weaknesses or defects in the process. And when they stack over each other, they lead to the defect that we see in form of error or adverse effect in the end result. So it's a very useful model to understand and solve the problem. There are two types of errors: active errors, also known as sharp end errors, and latent errors, also known as blunt end errors. The active errors, they are always, all the time, or almost all the time, involve frontline personnel, whoever the provider is. It's direct contact between the frontline personnel and the patient. So that's why it's called sharp end. Like there is actual uh, poke or actual strike happen out of that active error, right? For example, human machine interaction. If a nurse or whoever provider is trying to give IV fluid and push incorrect button in the pump, or pick wrong IV fluid at the moment of providing the service, that lead to an active error. Instead of giving, for example, dextrose, picking normal saline. That's active error happening from the frontline staff directly to the patient. The latent error, on the other hand, is accident waiting to happen, not yet happen, waiting to happen. Any failure of the organization or the design to prevent that from happening will lead to the error and lead to active error. For example, if a healthcare organization have multiple pumps, let's give a similar example to the wrong IV fluid. If a hospital have different kinds of pumps used in different locations in the hospital, and each machine has different way to function and different mechanism to adjust. That is a latent error, because maybe the personnel who work with different machines at some point mix the way they run the machine from one type to another, and that might lead to an error. So this is an accident waiting to happen, yet it's not yet happened actually. Now let's move to another type of medical errors, which is the near miss. A near miss is defined by the Patient Safety Net, PSNet, as an event or situation that did not produce patient injury, but only because of chance. So the injury does not happen because of chance. So the near miss is an error, and the error was actually committed, but the patient did not experience the clinical harm. So let's give an example. So let's say in a shared room in a hospital, shared between two patients, a nurse came with medications for both patients, and for a reason, she mixed the medication. So she gave the patient A, for example, a wrong medicine. That patient realizes that this is not his or her medication, and he didn't take it and talk to the nurse. This is not my medicine. So this is a near miss, because the error already happened. The nurse gave wrong medication to the patient, but the patient actually didn't take that medicine. Another example, if a doctor prescribed wrong medicine to the patient and the pharmacist caught that in the pharmacy before dispensing the medicine to the patient, that's also a near miss. So the actual error happened by describing the wrong medicine. That's usually happen when using computer system, like electronic medical record system. The list of the medications are aligned in alphabetical order. Sometimes by mistake, in a rush, while having a very busy day, a physician might click the wrong medicine, like the next in a row, instead of the correct medicine, by mistake click the next in the line. And that shows in the pharmacy, and the pharmacist realized that that's not a convenient medication and called the physician, and the physician corrected the mistake. So the patient actually didn't take the wrong medicine. This is a near miss, because the error happened, but the harm did not happen, either by chance, by a third party intervene in the middle, or whatever the cause is. So this is a near miss, and it's really need correction. Even the harm doesn't happen, it needs to be reported and corrected in the process, right? So near miss is a second type of medical errors. Now let's move to adverse events, which are different. So an adverse event is an injury that was caused by medical management rather than underlying disease, and lead to either a prolonged hospitalization or produce a disability at the time of discharge, or both. So there is actual consequence of the adverse event, right? They can be preventable adverse events, and those are avoidable by any means currently available, unless that means was not standard. So in other words, if the provider follow the standard procedures or protocols, this preventable adverse event would have not happened. Means the occurrence of preventable adverse event is due to negligence and failure to follow the protocols or the procedures that should be followed by any provider in your situation, with the same resources, with the same protocols. And if you fail to provide that care, and as a consequence of that, an adverse event happened to the patient, this is called a negligence. And this is one of the important and serious medical errors, right? Let's give an example. If patient came for sigmoidoscopy and the physician perform the sigmoidoscopy and report that there is nothing found, it's normal, steady, and after the procedure, immediately the patient complained of rectal bleeding. The physician or the surgeon reassure the patient that's normal and that happens and never mind. A year later, if the patient present to the ED with loss of weight, devastating condition, and found to have metastatic cancer, colon cancer, in this scenario, that provider in the first sigmoidoscopy done a year ago had failed to provide the early diagnosis that would have prevented this metastatic cancer from happening. At this time, this is counted as negligence and it's a preventable adverse event, right? So I hope this example is clear enough. The non-preventable adverse events, on the other hand, are not due to negligence, right? They are same like side effects expected to happen, but they happen due to a procedure or management that we provide to the patient, right? Let's give an example. The patient came for angiography and the procedure was done in a standard process and everything was done correctly. But as a matter of fact, the patient has a stroke afterwards, right? And the stroke is literally due to the procedure itself, but not due to any mistake done during the procedure. It's an expected side effect that might happen. There is a 1% of possibility that might happen, but nothing wrong was done during the procedure. Everything was done according to the standard protocol. So this is, yes, an adverse event to the procedure, but it's non-preventable because no mistake was done during the process. The last type or the third type of adverse events is the ameliorable adverse events. And those are not preventable, but the severity of the injury would have been substantially reduced if different action or procedure had been performed, right? So the word ameliorable means could have been done in a better way, make it better or lighter, right? So as an example, if a patient was admitted for heart failure and discharged from the hospital on furosemide diuretics and was given a follow-up after a month. Before the end of the 4 weeks period or the month, the patient presents in the ER with dehydration and found to have hypokalemia as a side effect of the diuretics. So there is an action, if had happened, would have prevented this low potassium from happening or detected earlier before the patient present to the ED, which is an earlier follow-up before the 4-week period given to the patient. For example, if the patient 1 week follow-up as outpatient and check the electrolytes being on diuretic, need to check the electrolyte after discharge in a shorter period, not 4 weeks, right? So that's why this adverse event is ameliorable. That means could have been ameliorated by earlier follow-up as outpatient. So these are the 3 types of adverse events, and these cases are adopted from the Harvard Medical Practice Study. And I'll put the reference in the reference slides at the end of the video. The last type I want to discuss here is the never event. And as the name implies, it's a major error that should never occur, never happen, right? It's an adverse event that is identifiable, it's serious, it's usually preventable, and in the first place, it should never had happened. For example, missing a Caesar in patient abdomen after surgical operation, or operating on the wrong side of a limb, for example, instead of doing a knee surgery for the right knee, operate on the left knee, right? So it's usually a big error that should never had happened. Never event in its worst scenario might lead to a sentinel event, which is a never event that lead to death or permanent harm or disability or severe temporary harm or disability. That's called sentinel event. In general, it should never had happened. So finally, what should health organization do for medical errors when they happen? Number 1 step is reporting. Why? First off, to learn from the error and to improve the service. And then after that, the quality department need to apply analysis. And the analysis can be retrospective in form of root cause analysis, which is usually has tools to perform like fishbone, cause and effect analysis diagram, or process mapping, or other tools well known by the quality personnel in any healthcare organization. This is called a retrospective analysis. Another analysis is a prospective analysis, all right? It's called the failure mode and effect analysis. And this approach is a forward-looking approach. This is applied before the process implementation for any process, any protocol, to prevent the failure occurrence in the first place. This one uses inductive reasoning to identify all the ways the process might fail and prioritize them, think about them, and try to find ways to prevent them from happening. So these two types of analyses are the procedures done whenever there is medical error to prevent future occurrence and to learn from the error that had happened. These are the references for this topic content. And in a separate presentation in the future, I'll talk about specific types of errors like diagnostic errors, medical errors, hospital-acquired infections, falls, and so on. There are certain types of error has special considerations. I'll try to cover that in future presentations. Thank you for watching this video, and I wish you a safe practice free of any avoidable errors. Goodbye.